Hi, everybody. This is Cheryl Parker. I am the president of the American Nursing Informatics Association, and I am so thrilled today to be joined by Kay Burke, the Chief Nursing Informatics Officer at the University of California, San Francisco, and her colleague, Jennifer Leos. She is an informatics nurse from the same location, and we've got some really great topics for you today, so we're just going to jump right in. Kay, one of the big things on everybody's mind is PPE and the stewardship solutions. So I would love it if you could tell me what y'all are doing out there in California.
Yeah, absolutely, Cheryl. Thank you. Sort of PPE supply, of course, is top of mind across the country. And here in San Francisco, we decided to proactively think about both low-tech solutions as well as high-tech solutions to ensure that we are preserving PPE when and where clinically relevant and applicable and appropriate. So from a low-tech perspective, a number of organizations have also alleviated some of the 2 RN checks specifically for high alert medications as well as blood administration. So we were able to reconfigure the electronic health record so that that check could be done outside of the room, and therefore only one nurse had to enter the room and don and doff PPE in a safe manner. Likewise, we're also doing some low-tech solutions in regards to lengthier tubes with any monitoring or medication administration that could take place out of the room. We are also leveraging inpatient telehealth. This has been particularly exciting. So we have implemented iPads at the bedside for all of our units in which there are any COVID positive cohorted patients. Mm-hmm. And this has been incredibly successful. It's been a huge clinician satisfier and a huge patient satisfier. So this is to remove the necessity of a clinician to go into the room if not necessary. So this is really even assessing pain, for example, that can be done via Zoom on the iPad. There are also ways in which you can have non-nursing, non-physician clinicians having any of their, so pastoral care, for example, has leveraged the iPads and these inpatient telehealth solutions to provide better care for their patients. So the chaplains are also live on this. As I said, many excited clinicians in regards to this solution. We also have piloted what I think is particularly exciting, Bluetooth stethoscopes. So needless to say, you need to have a stethoscope on a patient. However, we don't necessarily, being an academic institution and supporting our teaching mission, we also have interdisciplinary rounds that can take place outside of the room with one clinician in the room and assessing the patient with a stethoscope that is Bluetooth enabled. And so all of that audio takes place outside of the room. So that's being piloted on our unit that is actually cohorting most of our COVID positive patients. And again, another really innovative way that preserves PPE and is also a clinician satisfier in regards to limiting any possible exposure.
Makes perfect sense, but yet not necessarily the thing that jumps to the top of your mind.
Precisely. Yeah, it's that's, I mean, we're in the Silicon Valley, so in the belly of the beast when it comes to innovation. So we are really considering a number of innovative solutions that we perhaps did not in the past. And a lot of our sort of digital health solutions have been catapulted in the last 4 weeks. These have sort of been discussed in the last 6 to 12 months, and then boom, they're already live, which has been very exciting.
Jennifer?
No, I agree with everything that Kay's saying, just only to add that we're still, even though, you know, we've done quite a bit of things, we're still moving the needle to more telehealth initiatives. So yeah, we're doing a lot up here. And
thanks, Jen. I forgot to mention our outpatient telehealth. Our ambulatory visits are now enabled via telehealth 56%, whereas our telehealth utilization data prior to COVID was resting around 5 to 7%.
Wow, that's like huge.
Yeah, absolutely.
I can really see that this is going to change healthcare delivery even after we get through this. So,
Absolutely.
anything else we want to share on the whole PPD and telehealth, how we're using it?
Just one point to mention is that we also initiated the auto activation for MyChart to kind of help with telehealth initiatives as well. And then we also have something called on the fly visits, where you could just start a telehealth visit like from a phone call, things like that. So you don't have to be on a schedule. So those are other things for outpatient.
I'm curious, are you using this iPad solution to connect families? Are you letting families in, and are you using it for them?
Yes, so we are. So the iPads are able to be leveraged for family communication. It's not required to have a secure solution in that case because this, for obvious reasons when it comes to the platform required for care delivery. So they are able to just use FaceTime or another capability enabled by the iPad. Whereas the official inpatient telehealth work streams, we use Zoom.
Okay, super. All right. How about if we move on to data analytics, the visualization? I know you guys are big at that. One of my dear friends works at UCSF, and I know that's kind of her realm of life. So I'm interested to know what y'all are doing in that realm.
Yeah, absolutely. So we have established a centralized data analytics visualization team, which sounds probably pretty simple. However, at an organization like ours that is very research focused and, as you said, extremely advanced when it comes to data analytics, it was definitely a little bit of a feat to pull in all of these groups. However, we've developed a real-time executive dashboard. So this not only includes our current census with all of our COVID positive patients and those patients that are pending, as well as our PUIs. So these are, persons under investigation. And we also have a lot of trended data so that our executives in real time can see not just what we're treating in-house, however, what our trends are looking like at UCSF. We also have data around healthcare workers that is intended to be on the executive dashboard in regards to how many of our own employees have tested positive for COVID and where was that source of transmission. And so that's also going to be a really transparent mechanism for everybody across UCSF to understand where we are and how we're faring during this pandemic in real time. That said, there are a number of dashboards and analytical solutions underneath those that are rolling up to that, including Peri-Up. So for example, everybody is canceling their elective surgeries. However, these elective surgeries are not ones that can wait 6, 9, 12 months. Perhaps there's also some low risk oncology procedures. I mean, there are some non-elective procedures that are critical. So we have data to support which of those surgeries, when we're able to start to reschedule them, are higher priority. Again, transparently reported out to the enterprise. Likewise, we have a health equity lens to our data. So we have a really strong mission in our diversity, equity, and inclusion True North pillar to always ensure that the care that we deliver and how we are providing that high quality care has consideration for the eradication of health inequities. And so we always are looking at sort of, race and ethnicity data, for example, and language. There's a number of publications out there that say that some of our higher acute COVID patients in the States are are those that are perhaps a little bit more in the underserved categories of race, ethnicity, and language, which is a real sobering thought that how we're delivering care in this environment perhaps is not equitable. So all of our dashboards also include a health equity lens so that we are always cognizant of how we are caring for our patients that is of high equity.
Super. I actually spent a lot of time at UCSF several years back when I was in the consulting world, and your patient population is extremely diverse. So I'm going to be fascinated to see the research and the articles that are going to come out of you guys. And I'm just going to say one thing, Kay. I love the emphasis, but don't beat on your desk.
Oh, okay.
It comes across in the mic. I had to learn that. I like to do that, and it's like, okay. Ooh. So let's continue on. The whole thing, you've got down here about centralized and federated efforts. I'm really interested to know what you mean by that.
So this is the interesting part of pulling together an enterprise-wide analytics team in short order, when really we have had siloed local analytics, very advanced analytics, but within different departments. So for example, our infection prevention team, locally embedded in the Department of Quality, they had advanced analytics that they were reporting off of. Our people analytics, living in HR, for example, that is appropriate to live in the Department of HR. We also had Tableau dashboards that were federated in the finance department. These are three examples of data sets that, without correlation, don't actually present really how we are faring during this pandemic when it comes to our healthcare workers who were not cleared to work because they failed the screening, and how much that might impact our census our staffing ratios. And then financially, what does that cost us from a workforce perspective? And then overlaying those data with other data sets that were perhaps never correlated. So these federated analytics shops, so to speak, were all centralized within 2 to 3 weeks. And this is how we have really been able to develop keen insights that are comprehensive in how well we're doing and where we need to focus attention, because we are new to this, as is every health system across the world. And we believed that having a data-driven approach to how we are prioritizing all of the work that needs to be done. And we were able to leverage Tableau as our, as our platform to both prep and analyze data based on your role and what problems you are trying to solve.
Yeah, if you have any information on that at some point you can share with the people who are watching this, how you did it, maybe documents or anything that says this is how we're going to work together, I'm sure everybody would be interested if you can provide those at some point.
Absolutely.
I get how busy everybody is, but it's like, let's not recreate the wheel any more than we actually have to. But that's really great. That is not easy to bring that many people together.
It really wasn't. And it has been one of, there have been many exciting and humbling moments over the past month, but one has been this overwhelming willingness to collaborate like I've never seen before. And a great example, shining example of that is this new data analytics visualization team that I believe we will one day be able to publish the work that we've done. But any materials that I can collect and send your way, I'm happy to share.
Yep, because we will share them out with as much of the informatics community as we can reach. Jennifer, anything you want to add to this part of the discussion?
Well, just the view of, besides the summary, like the big overall big pictures that, Kay's been talking about with the data analytics, we also have like the bedside physician, the bedside nurse, like the front line. Some of the new data that we also created, just for their day-to-day, to make sure that, they know a list of patients, they understand a workflow, like this is new data, like this flagging for, not isolation, but, like these tests and things like that. So just new things that we created, and also just, collaborating between the systems, so between our hospitals. That way that is trickling up, you know, so we have the same, we're all doing the same thing instead of like variations of like, you know, 3 different kinds of order sets and, you know, things like that. So just, it's still the, what is it called? Like from small to little, like the Russian dolls is what I like to think of it.
Yeah, the nesting dolls will get big and
Yeah.
little and
Yeah,
little
just
and
keep going.
little.
Yeah.
I'm really curious. I know we didn't prep this particular question, but do y'all have any of the remote sites that some of like New York is using right now? And if you do, how are you keeping patient identification as they move from site to site, or is that an issue for you guys?
That's an issue, to be honest with you. So contact tracing is, it's sort of, I've said a few times, now's the time we all wish we were wearing those Walt Disney World bracelets where you are tracked, you know, every step that you take, because it's difficult to understand when patients become symptomatic and then when they are tested, and that time period for the, you know, the turnaround time of the test, and then when they become positive, to really, it's like a fishing expedition to determine their, the source in the community, whether it's somebody within their household, if they're in a congregate setting, for example, a long-term care facility, perhaps even a homeless shelter or a jail. We are really struggling with that patient identification piece. From what I've read, I believe other countries are able to more effectively leverage sort of cell phone data for geolocation. And as I understand that we in the States are sort of having a hard time with effective patient identification and contact tracing.
Yeah, I was thinking not so much from the contact tracing, but more from the, if you have remote, like remote testing or remote hospital sites, and you've got a patient out there and then they have to come into your facility, are you having any issues with tracking them from like a remote site, or are you using any remote sites like tents, pop-up hospitals, field hospitals?
Yeah, so we have 2 ACUs, accelerated care units, that are essentially tents outside of the ED. Our network is pretty broad, and so we already have interoperability with our affiliates. We have not actually, fortunately, had to use any of those pop-up remote care locations.
Okay.
We're fortunate. San Francisco and well, the Bay Area, but in particular San Francisco, has not really seen any kind of surge like the East Coast and other pockets, including Detroit and New Orleans. So we're seeing the curve really flattened here, and we've been pretty fortunate to be more prepared for a surge if and when that peak does arrive.
Oh, that's great to hear, and we will hope that you stay flat and start going down, because we certainly don't want a second round of this.
Yeah, Cheryl, can I just go back to data analytics, because
Sure,
Jen
absolutely.
triggered my memory in regards to one thing that I think is really important to mention. So thank you, Jen. We also enabled dashboards at the unit level, which we had never done before. So for example, bed planning. We had always centralized bed planning tools to the bed planning department. So the only persons that had access to where patients were going next and how beds were assigned were the central patient placement office. We now have a lot of those bed planning visualizations on monitors in the units with, to Jen's point, infection flagging awareness, so that when you walk on the unit, you know exactly which beds are open, which beds have COVID positive patients, which beds have COVID pending patients. We've also developed dashboards in regards to where our negative pressure rooms are located, how many are left, and where those are. We also have enabled a number of dashboards that tell everybody down to the frontline nurse, what is our current census, what is our surge status. So we have thresholds in regards to how many COVID positive and pending patients there are. And then we have different clinical workflows when it goes from green, yellow, red, and hopefully never black. So we've done a really great job at not just developing these executive dashboards for sort of more leader consumers, which is typically how health analytics is is constructed and delivered, but rather to the direct care clinicians so that they are more informed in real time, so that they are much more aware and even to an extent comfortable delivering care in this new world order, which everybody, needless to say, has anxiety around.
Oh, that's phenomenal to hear. Again, one of those things that's, I think, going to change how we deliver healthcare in the future,
Absolutely.
of pushing information down to the lowest level that needs it, whether it's, anybody in the facility, or even better, say everybody in the facility, because literally everybody needs to know who your infectious patients are, who's coming. That's phenomenal.
Yeah, and one of the really beneficial byproducts of this, and I know we as informaticists live and breathe this, but it has enabled data literacy at the front line. So direct care nurses that are understanding why data, transforms their practice and how that can happen. And I think that's kind of what we're all after in nursing informatics. And I'm thrilled that it's crystallizing much more quickly than I've seen in the last 12 years of being in this field.
I've been in it for 25. So yeah, I especially those first years that were such a slog going, can you imagine doing this in the paper world? I don't even want to think about, that was my first 20 years of practice. I don't even want to think about that, what that would have been like if we were still in that world faced with this.
Yep, absolutely.
So, yeah. So, mobilized testing, results management, all that kind of stuff. How are you handling that?
Yeah, Jen, I might let you take the lead on that one. You've been a lot more central to that work.
Well, for mobilized testing and result management, so we did a couple of things here at UCSF based on discipline and based on need. For example, in the ED, we utilized Rover mobile applications for nurse workflow. We also, in the ACU units that Kay was talking about earlier, that's right in front of the ED, we started to utilize Can2 or the iPad workflow for providers. And so there they have access to order, and they also have access to, review tests and things like that. So besides the workflows with that, we also wanted to utilize, for example, the Rover mobile devices as a way to expand our ability to do charting and to do just nimble charting for, medication administration, or where we want to just do, just quick overview of patient, like in on the patients, like how are they? And this was to help us with surges. For example, if we had patients in the hallway and we didn't have enough wows, or the laptops on wheels, I guess you want to call them, or if we needed to put somebody in a different aisle or in a different, outside of the ED, and we were bringing in nurses from somewhere, this was a way to manage, having more ways to chart or to access patient charts in an efficient way. So that's what we implemented here. And so those are the two device managements that we're doing now. I don't know if there's other ones, Kay, that you know of, but that's the ones that we did for COVID.
So just to add to that, using the mobile app for electronic health record documentation for most of nursing's point of care workflows was also really exciting. We've been trying to push that for 2 years, and we're able to implement that in 3 weeks. That was also, to Jen's point, to prepare for when our surge hits, what minimum documentation standards will we be able to more quickly enable, particularly as we have patients that are not in areas that can be enabled by a WOW for documentation. We've also used some technology platforms for testing results that initially were negative, and we were able to notify those patients with automatic calls and scripts telling them that they were negative. And the reason that we automated those processes, again, in preparation for a high volume of calls with our humans wanting to communicate the positive results and what are those post-acute instructions. And so really automating the negative results so that we had enough bandwidth to cover the positive results outreach. And that was implemented right away. And I think that's also been a huge satisfier to ensure that we have the right people working on the right work and preparing for surge and high volumes as this progresses.
Well, that's super. I know we are on a hard stop deadline for you guys, so I just want to say, is there anything else you'd like to share with the folks listening before we close up?
Well, I guess one thing is I'm sure everybody is feeling the same way that we are, in which this interview highlights a lot of great progress and showcases work that's been done. But this is evolving, and now we're talking about how to test asymptomatic patients. How do you ensure that testing has been completed and patients are cleared for you know, their upcoming caths, for example, or their upcoming surgery? There's still a lot of work to be done, and I know that I feel daunted sometimes when I read articles about organizations that have done everything perfectly and they just knew how to, you know, how to launch every innovative work stream. I think we've all really kind of figured out what we can do in the right time, but also can learn from each other. So, you know, I look across the industry to my peers to see what we can be doing better, and I'm humbled by everybody else's great work.
Super. Jennifer, any last comments from you?
Well, everything I agree with Kay, but I did want to mention one more great thing we're doing is sometimes we forget to care for the caregiver. And so we do have a couple of mobile solutions for staff that we're still working on. So one of them being just a workflow, I think it's called Conversa, but it's basically, you know, where staff can text, you know, their symptoms, and then they can be routed to either A, come to a drive-through, or B, you know, come into work and get cleared. And then the second thing that's new, that's innovative, is that staff is the possibility that we could even have some, not counseling, but, you know, for staff to reach out if they need to talk to someone amongst this crisis. So, yeah. So just looking at it all the way around, patients and staff, you know, we're all in it together.
How we can use the technology to really support the workflows. Y'all have done a phenomenal job. I want to thank you so much on behalf of the American Nursing Informatics Association and all the informatics nurses out there to take your time to share. We wish you the very, very best. Stay safe. If there's ways we can help you, if organizations out there can help you, please let us know, and we'll certainly act as brokers for you.
Absolutely.
Thank you again so much. Have a good day, and my thanks.
Thank you, Cheryl. Bye-bye.
Bye, y'all.